Hi, good evening, everyone. So let us start with this revision session. So I'm Dr. Saurabh Dixit and I welcome you all to Unacademy. So before I start, let me tell you just about the iconic subscription where you can get Unacademy and Preparated both at a very good competitive price, and we have special classes loaded with all these features. You can use them. Raise a hand is really awesome. It's really an awesome feature. And don't forget to make the maximum use of the question bank, which is really very good and loaded with more than 25,000 MCQs. So let us quickly start with this session. Okay. Yeah. Let us discuss this question. Come on. All except are indications for splenectomy. So all except are indication. Good evening, Varsha Beta. God bless you. So all except are indications for splenectomy following splenic trauma. Yeah. Come on, tell me. So when we talk about splenic trauma, let's say virtually all four of them are right. If you see all four of them are right, we have to choose one best answer. The answer is contrast blush. You know contrast blush because many people tease that contrast blush is an indication for splenectomy. No, not at all. Majority of the patients can be managed with angioembolization. Is that clear? So let us try to understand something about the splenic trauma. So we're going to talk about the splenic trauma and then we're going to discuss about the grading. So this is a very today I'm not going to have a very long session. We'll have 2-3 important topics discussed today. So one I have selected as a splenic trauma. Splenic trauma is a very important topic for your exam. So when we talk about splenic trauma, you get a lot of questions on splenic trauma, and basically you get the questions on grading as well as management. So you get a question on grading of splenic trauma. When we talk about the grading of splenic trauma, the most important thing that we all have to understand is on the basis of contusion, what is the status of the spleen, and on the basis of laceration. So on the basis of laceration, on the basis of contusion, let us try to understand this. Yeah. So on the basis of contusion versus laceration, grade 1. What is grade 1? Less than 10% hematoma, less than 10% hematoma, or less than 1 centimeter, less than 1 centimeter laceration. Grade 2, if you talk about 10 to 50% contusion or hematoma, or students, or 1 to 3 centimeters of laceration. Grade 3, if you talk about more than 50% of the contusion, more than 50% of, you can say, hematoma, and more than 3 centimeters of laceration. Apart from that, what is grade 4, students? When we talk about grade 4, it is more than 25% devascularization. So more than 25% devascularization. This is what is grade 4. And actually this actually qualifies for hilum injury. So this is equal to hilum injury. What is grade 5, students? Grade 5 is complete devascularization. Complete devascularization. Now when we talk about complete devascularization, this is grade 5, and there is one more thing which is included in grade 5, and what is that? That is a shattered spleen. So shattered spleen is actually a grade 5. Now whenever we talk about the management of splenic trauma, there's a rule. What is the rule? You can live without a spleen, but you cannot live with a bleeding spleen. This is very important, very important. Let us try to understand this. So whenever we have a patient of splenic trauma, the next thing that you have to understand is whether the patient is stable, or the patient is unstable. Students, if the patient is unstable, then you don't have to wait. You have to go for surgery. And remember, it's better to remove the spleen. So prefer spleen over life or prefer life over spleen? Yes, of course, we'll prefer life over spleen. So splenectomy is the call. Now, if you have a stable patient, what we'll do, we'll get a CT scan done. So CCT done. Now CCT will show you a lot of things. First is, it can show you a pseudo aneurysm. You know, I know, everyone knows that pseudo aneurysm, the treatment of choice for pseudo aneurysm. What is the treatment of choice for pseudo aneurysm? Answer is splenectomy. Do you know splenectomy is a call? Why? Because it's a pseudo aneurysm, it can rupture anytime. The second is subcapsular hematoma. Do you know, normally we don't look at the organs with subcapsular hematoma, we just leave them. But splenic subcapsular hematoma is a unique condition where the hematoma keeps on expanding under the capsule and it will actually erode into the splenic parenchyma, and after 2-3 weeks there will be a sudden hypovolemic shock because of the splenic rupture and the patient will die. Remember, initially the subcapsular hematoma patients are absolutely stable, but after 1 or 2 weeks this catastrophe is going to happen. When you know that this is going to happen, will you take a chance? No, not at all. So students, take my words, subcapsular hematoma of the spleen is a unique entity where, despite the fact that it qualifies for actually grade 1, a subcapsular hematoma of any organ, is actually a grade 1, but this is the only exception where a grade 1 is getting managed with a surgery. And what is the management? Yes, splenectomy. God bless you, Kajal bache. Okay, the third is we talk about the grade. Bache, if we on CT scan, if we talk about the grade, we can have grade 1, 2 and 3. For grade 1, 2 and 3, you are going to go for observation, isn't it? You're going to go for observation. You don't do anything for them except if it is a grade 1 subcapsular hematoma, because you know that right now the patient is stable. But how long the patient will stay stable, no one knows. And there is a fate of rupture. Rupture is going to happen. Next is, let us talk about if it is grade 4 and 5. Students, if it is grade 4 and 5 splenic trauma, what is the call now? The call is you have to go for surgery. Now, when we do go for surgery, practically, if you say, we only do one surgery, that is known as splenectomy. We go for a splenectomy. Is that clear? We go for a splenectomy. Now remember, what are the other options? We also have an option of splenography. When you talk about splenography, what do we mean by this? Bache, this is done only if more than 50% of spleen spared. So if more than 50% of the spleen can be spared, then only do splenography. Otherwise there is no point, because the splenic volume which is actually required for normal function is 50%. Then fourth finding on this CT is a contrast blush. What is a contrast blush? Bache, contrast blush is equal to leak of contrast from the marginal vessels of hilum. So you know, I know, everyone knows that the splenic blood supply is a bit different than other organs. So this is the main supply which is coming, and then it will bifurcate into small you can say branches. Similarly, this is going to come from this and it is going to join to form a renal vein. So if any of these small branches is showing you a leak of contrast, the patient was hemodynamically stable, but when you went for CT, you saw this contrast blush. Remember, this is by default, since it's a marginal vessel involving the hilum, this is by default grade 4. This is the only grade 4 where the first line, and this is also many a times the treatment of choice. What is the treatment of choice? Angioembolization. Students, if it fails, then only you are going to take that patient for splenectomy. So let us get back to the question. If you see the question, all except are indication for splenic trauma. Pseudoaneurysm, yes, otherwise it will rupture. Subcapsular hematoma, absolutely right, because you know the subcapsular hematoma is going to erode into the splenic parenchyma. Hilum injury, of course. Bache, contrast blush is also, C is the answer of exclusion. C is the answer of exclusion. Why it is answer of exclusion? Because for contrast blush, the first line or the treatment of choice is not a splenectomy, it's angioembolization. But you cannot deny the fact that you can also go for splenectomy for this. Let us move forward and let us go to next question. Okay, so tell me this. This is a very easy question. Best way to remove obstructed follies. Come on. So best way to remove obstructed follies. Do we go for chemical dissolution? Do we go for overinflation with the saline by 20-25 ml? Or you go for USG guided, or you go for cystoscopic removal? It's a very easy question. Do you know what is the reason for these adhesions? This is the bladder. This is the bladder. Yeah. Try to understand one very important thing. This is the follies. This is the follies. Yeah. I'll discuss. Don't worry. I'll discuss. Not today. Tomorrow. Next turn I'll definitely discuss, because today I'm not going to take a very big class. So just had a routine. So I was planning to take a class. So, bache, you infiltrate this bulb. You instill saline or a distilled water. Generally, we prefer distilled water. So sometimes what happens? There are adhesions in between the bulb and the bladder. So there are adhesions. Very good. Not very late. Yeah, but it's not. We have discussed one question only. So adhesions, because of the adhesions between the bulb and the wall. Point number 1. So between the bulb and the wall of bladder, you get to see this. This is the first reason. The second very important reason is maybe because of the precipitation of the crystals. So you can get a question why it can get obstructed because of the precipitation of the crystals. You know, sometimes we may actually use normal saline and then it crystallizes. So in that case, it actually gets blocked. Now, how to manage this? Answer is, students, the first line is, do you know the bulb has a maximum capacity of 20-25 cc? Generally, we inflate 10 ml, 12 ml, it's sufficient. So if you push 20-25 ml extra, what will happen? The bulb will actually get ruptured. So the bulb will get ruptured if you push extra fluid. Yeah. So the first line is, don't pull it. Yeah. It is overinflation with 20-25 ml of normal saline or of NS. This is going to rupture it. Students, if it is not able to, what to do? You know, this is pubic symphysis. Under the USG guidance, what are you going to get? You're going to get a long, thin needle. What is this needle known as? This is a spinal needle. So what you're going to get? You are going to get this. And you're going to puncture it. So what is this? This is USG guided. So USG guided suprapubic puncture. This is the best management. But yes, it is reserved only for the cases where you're not going for. Yeah. But say in an era when you did not have ultrasound, what do we used to do? We used to push ether. So chemical dissolution was done with ether. So there ether was utilized. But do you know, if you are using ether, the chemical will leak into the bladder and will result in very severe chemical cystitis. Are you getting? So bacho, why the chemical dissolution is actually contraindicated? Because of the risk of chemical cystitis, and therefore this is absolutely contraindicated nowadays. So best way is USG guided puncture of the bulb. Now I'm going to ask you one more question. Suppose this is question. I'm going to ask one more. Suppose question 31B. What is that? If the question is all except, the question is all except are ways to remove obstructed follies. Now tell me. So all except are the ways to remove obstructed follies. What is the answer now? Bache, the only answer is, how can you insert a cystoscope? Because catheter is already there. So you can remove it with A, B and C. But you cannot go for a what? Cystoscopic removal. Bache, cystoscopic removal to possible ही नहीं है. Yeah. Because already this. So D is the answer for this. Are you getting this? So D is the answer for this. Let us discuss one more easy question. Okay, tell me this question. This is a very, 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 very easy question. Yeah. Tell me something about modified shock index. They could try to understand one very basic thing. That whenever we are monitoring a patient of shock, the first or the commonest parameters that we see the pulse, yeah, and we also see the blood pressure. This is what we are seeing. Individually, they don't have a good, you can say, a prediction. They don't have a good prediction. Yeah. So if we actually integrate the pulse and the BP together, yeah, if we actually integrate the pulse and the BP together, we'll get an index which is known as a shock index. So we integrate both of them. We integrate both and we get something which is known as shock index. But so what is a shock index? A shock index is defined as heart rate upon SBP. Is that clear? So heart rate upon SBP is considered as shock index. Now what is important is a shock index, a normal shock index is generally 0.7. Normal shock index is considered to be 0.7, roughly around 0.7. Yeah. Now, bache, you know that mean arterial blood pressure is a better predictor of the, you can say, blood pressure status. So what is MAP? Tell me, what is MAP? By MAP we mean modified shock index. So remember how, like many of you have got confused. This is defined as heart rate upon mean arterial pressure. Always remember it like this. S for S, S for SBP, and modified M for M. So denominators, you just remember it like this. Now let us see the condition. Let us see the condition where the shock index is changing. So let us talk something about the shock index. You know that there could be two predictions. Either the shock index can increase or the shock index can decrease. Student, when will you have an increase in shock index? You'll have increase in shock index in cases when you have tachycardia. Yeah, tachycardia. When are you going to have hypovolemic shock? When you have less blood, it's giving you more circuits. Yeah. So the pulse rate is already increased. So hypovolemic shock. Same is the case with cardiogenic shock. Heart is releasing, the cardiac output is low, so heart rate is more. Yeah, cardiogenic shock. The third is because of SIRS in case of septic shock. So in case of septic shock, because of SIRS. Now when you talk about the decrease in shock index, what is the reason behind that? Yeah, the reason behind that is a bradycardia. So bradycardia. So what could be the reason? But in neurogenic shock. In neurogenic shock, the shock index is going to decrease. So neurogenic shock is the answer for this. Yeah. So for today, I'll just wind up the session. If you like the class, do join Unacademy Plus program. Use the code Dr. Dixit. You can also unlock the special courses. So special and plus courses, you can use the code Dr. Dixit there. Do follow me on Unacademy by clicking the button of follow button. You can get on YouTube link also. You can get that on YouTube link also. So do follow me on app so that you don't miss any notification for my classes. So I hope you enjoyed. So we'll just every day we'll have a small session of revision of 2 or 3 questions and a concept so that we can just stay strong as far as the subject of surgery is concerned in preparation. So I hope you enjoyed. Do give your feedbacks and do share the link with your friends also. Till then, bye bye. Good night.